Good evening, doctors. My name is Ankur Gautam, and on the behalf of FDC and my talks, I welcome you all to yet another episode of 52 Weeks with Dr. Sanjay Kalra, Season 3. Today's topic is a very interesting topic, diabetes and fertility. Diabetes Essential is brought to you by your zero calorie electrolyte drink, Result Zero. Now, before moving forward, I would like to announce last week winners. Dr. Shantanu Kumar Bhattacharya from Kolkata, Dr. Prachita Srivastav from Thane, Dr. Kaval Saluja from Mumbai, Dr. Surjit Kalsi from Noida, Dr. Anil Upadhyay from Barabanki, Dr. Girish Giswata from Mumbai, Dr. Shashi Khare from Bhopal, Dr. Ashutosh Das from Tumluk, Dr. Satish Kumar Jain from Bangalore, Dr. Rakesh Mohan from Ghaziabad, Dr. Pradeep Patro from Chhatarpur, Dr. Praveen Gupta from Jind, Dr. Nakul Bansal from Panchkula, Dr. Vilas Unavane from Ashti, Maharashtra, Dr. Ravi Bhatt from Sirsi, Karnataka, Dr. Sanjeev Puri from Hoshiarpur, Dr. Ashwani Kumar from Kanpur, Dr. Sharad Zatakia from Mumbai, Dr. Sumita Sharma from New Delhi. So thank you all the doctors to take part in our quiz. Now, to enlighten us regarding today's topic, I would like to welcome our host, Dr. Sanjay Kalra, past president, South Asian Federation of Endocrine Society, and chairperson of Education Working Group, International Society of Endocrinology. Welcome, sir.
Thank you, Ankur, and good evening, everyone. As some of you would have noticed, and we welcome Dr. Gauri Shankar from Karnataka as well. My designation has changed. I remain Sanjay. I remain Sanjay Kalra, your familiar, friendly, and faithful uh, partner in our fight against diabetes. But I had been working, I had been serving as president of the South Asian Federation of Endocrine Societies for the past year. I've stepped down now, and I'm very happy that I've been able to hand over my office to a very capable pair of shoulders, very capable pair of hands. That is Professor Rakesh Sahai from Osmania Medical College in Hyderabad. I also stepped down as president of the IPATH, which is Indian Professional Association of Transgender Health. And what this means for me now, my professional career, is that I will be able to spend more time, more energy on diabetes essentials because this is something that I really, really love. I have traveled over the country in the past few months, and when people come up to me, when all of you come up to me and say that you've been watching diabetes essentials, it has helped you, it has helped your patients in practice. That makes me really happy, and I think for me the definition of satisfaction is that everyone is happy, is in harmony with each other. There's no ladai jhagda, there's no fighting, there is aman shanti, peace everywhere, and also that our patients are being served in the best way that we can help them. So, keeping this in mind, let's continue with our series of glucocrinology. In this, what we've been doing is we've been talking about various aspects of endocrinology related to diabetes. We've talked about the pituitary, the thyroid, the adrenals, bone. Today, let's talk about gonads. And in gonads, we'll speak about fertility. Now, when a person comes with diabetes, one of the first things that we do is we ask the age, we ask if they're married or not, and then we go on to take their history. In women, especially women living with type 2 diabetes, the risk of subfertility is more. Also note that type 2 diabetes is occurring earlier and earlier in both men and women, and the age of marriage is increasing. So age of marriage may have gone up in the past few decades from maybe 15 to 21 to 25. And if you're serving a very highly educated class, then 25, 30, 35 years is not uncommon. Age of marriage of women. Also, all of us will agree it is not uncommon anymore to see 25, 30, 35-year-old women presenting with type 2 diabetes. So the chances of having a woman in the reproductive age group who has diabetes and who is still planning a family are much higher. Apart from that, women with type 2 diabetes and with type 1 diabetes are also increasing. The incidence of type 1 diabetes is going on. They are surviving for longer period of time. And we more and more frequently see women with type 1 diabetes coming with subfertility problems. Once infertility or subfertility has been diagnosed in a woman with type 2 diabetes, the risk of poor outcomes is higher. So the risk of not being able to achieve a pregnancy is 3 times higher in women with diabetes as compared to those without. And even if pregnancy does occur, the risk of miscarriage or abortion is again higher. The risk of congenital malformations is higher. So, in a nutshell, women with type 2 diabetes have a greater risk of subfertility and they have a poor prognosis of subfertility management. Not only that, even if the family is complete and they're not married and they're not worried about fertility, they still have a greater chance of having oligomenorrhea or secondary amenorrhea. In fact, when we were students, one of our professors used to say that the commonest cause of secondary amenorrhea in women with diabetes is not pregnancy, it is poor glucose control. This was in the old days, about 2.5 decades ago. So at that time, the moment you would institute good glucose control, the periods would start all over again. So our professor would tell us, do not investigate, do not do expensive tests. You ruled out pregnancy, that's fine. Withhold the other tests until you've got good glucose control. Do remember also that in the reproductive years, if your patient is planning pregnancy, it is a good idea to put the patient on insulin. Do good preconception counseling. Tell them that the tablets may be associated with harm to the fetus. We will give insulin. And once we've given insulin, insulin is a natural product. Once we've controlled glucose, then you are exactly the same as another woman without diabetes because your glucose levels are the same. You also have to tell her that in preconception and especially during pregnancy, we need very tight control. So our target will be fasting 95, postprandial 1 hour 140, postprandial 2 hours 120. These are our targets. 95 fasting, 140 at 1 hours post meal, 120 at 2 hours post meal. And if you're able to achieve this, the example I give is, see, I'm wearing spectacles. If my spectacles are fine, I can see as well as you can, which means I am not disabled, I am not diseased. However, if I take off my spectacles, then I will certainly be disabled and diseased. So, therefore, if you are able to take insulin, keep your glucose at these levels, there is no concept of disability, dysfunction, or disease in you. You are as healthy as anyone else. Women with type 1 diabetes may have a delayed menarche and a premature menopause. So the reproductive window is also less. In fact, some of them will have not only a premature menopause, but something that we call POI, premature ovarian insufficiency. So, therefore, they should be counseled not to delay planning. That doesn't mean that everyone with type 1 diabetes gets married at age 18, but we should just be sort of we should follow good common sense. How do you check for the ovarian reserve, ovarian function? Ultrasound usually will not help. You can get AMH done, anti-Mullerian hormone done. If the AMH is high or it is normal, that means there is adequate ovarian reserve. However, in women with polycystic ovary syndrome, AMH may be falsely high, so it may give you a false sense of security. On the other hand, now there is research that girls who have an early menarche, who go into menstruation early, those who have an early menarche, are at greater risk of developing polycystic ovary syndrome and also metabolic syndrome and type 2 diabetes later on. And they are at greater risk of developing cardiovascular disease after menopause. So, delayed menarche is also associated with reduced reproductive function, but early menarche is also associated with increased risk of metabolic disease. Now, our topic for today is diabetes and fertility. We've spoken about women and we've understood that you should take the menarche history. If it is too early, too late, be more cautious, be more vigilant. If it is a woman with type 1 or type 2 diabetes, ensure good control, adequate control. We have told you the targets fasting 95, PP 140, and 120 at 1 hour, 2 hours. If it is a woman with type 2 diabetes who's planning pregnancy, then ensure that the patient is on insulin, has good control before planning pregnancy. Tell the patient that insulin and glucose control is actually meant to help you and help the fetus, help the baby. So, if we can give a healthy atmosphere, healthy environment to the baby, to the fetus, he or she will grow up to be strong and healthy. Now, men with diabetes also have greater risk of subfertility, and the causes can be pre-testicular, testicular, and post-testicular. Pre-testicular means that either there is an issue with the hypothalamus or the pituitary or the overall health of the patient. These are central and peripheral mechanisms. If the hypothalamus and pituitary are weak, there will be less GnRH, gonadotropin releasing hormone from the hypothalamus, and less gonadotropins, that is FSH and LH, from the pituitary. If you have inadequate LH and FSH, there will be no stimulation of the testes, and then the testes will not be able to produce testosterone. If you have less testosterone and there is less semen production, spermatogenesis in the testes, obviously there will be subfertility. There are peripheral mechanisms as well. Now, supposing the thyroid is dysfunctional, patient has renal failure, liver failure, the body's defense mechanisms will go to fight that. They will want to survive. And all the energy, all the focus on the testes, that will be taken away. And the testes will not be able to secrete adequate testosterone or sperms. How do I explain to my patient? So usually when I'm getting test done for infertility, I draw a picture, a very simple, childish kind of a picture, and I say, see, the testes produce semen. So what are the possibilities? It is possible that the factory is not working, not producing semen. That is a testicular cause. There can be multiple factors in the factory. Yeah, maybe there's no electricity, there's no raw material. That's why there's no production. Or there is enough raw material, there's enough electricity, but maybe the people who are working, the workers there, are not doing a good job. So that is why the semen that is coming out, the sperm that is coming out, is damaged. It can be that, or it can be that the foreman is absent. The workers are there, they have all their machinery in place, they have all their raw materials in place. The foreman has gone off to sleep. That is the hypothalamus or the pituitary. And because the foreman is not supervising the workers, they're not working. Another issue is that the foreman is at work, the workers at work, they've done a great job, they've brought out the best, they want to bring out the best sperm. But suddenly electricity goes away because they say there's a blackout throughout the rest of the body. The liver is suffering, the heart is suffering, that's heart failure, or the kidney is functioning. So the big boss decides that I would rather preserve electricity in the heart and kidney and liver because these are essential for life. The testes is not essential for life, it is essential for uh, the next generation. So the big boss says, I will think about the next generation later, let me keep myself safe first. So that is peripheral mechanisms. And then another way that we explain to our patients is that now everything is fine, the workers in the testes, the cells have developed, have produced very good sperm, but there is a blockage. There is a blockage in the urethra. The sperm cannot reach outside. So that is why you have azoospermia. Apologies. And this azoospermia can be corrected by surgical means. To check between the difference, you have to do different tests. Now, if it is a central issue, LH and FSH will be low. If it is a testicular failure, primary testicular failure, LH, FSH will be very high and you will have low testosterone. Sperm count will be zero in absolute hypogonadism. But in diabetes, usually we have what is called oligospermia. Oligo means less, oligospermia. We also have asthenospermia. Astheno means lazy. So the sperms are lazy, they are not very motile. And most of this abnormality occurs because of testicular dysfunction. There is increased oxidative stress in the testes, increased production of reactive oxygen species. This leads to fragmentation of DNA in the sperm and weakness of the sperm mitochondria. So the sperms do not they do not form well and they do not fly well. There is also increase of AGEs, that is advanced glycation end products, and this is common in people with type 2 diabetes, common in people with obesity. So the treatment is to give good glucose control and also to prevent obesity. So give good glucose control, prevent obesity, add antioxidants if you wish, and also promote a healthy diet. At the same time, look for other hormones. The two main ones that we would check, apart from LH, testosterone, would be prolactin and TSH. If your patient gives you a history of loss of libido, if it is male, we will do three tests: testosterone, LH, testosterone, TSH, and prolactin. If it is a woman presenting with loss of libido, then we will check prolactin and TSH, two hormones. Which are the nutraceuticals that I use? So I do use nutraceuticals. I use coenzyme Q, zinc. These are the preferred ones. Uh, we also, depending upon the patient's history, what kind of libido the patient has, sometimes I use uh, salbutamine, which is activated vitamin B1, thiamine. At other times, I use yohimbine, which is a nutraceutical, and sometimes we use drug uh, like maybe testosterone. But testosterone you will use only if there is documented testosterone deficiency. So these are some of the drugs that we use in managing subfertility. At times, our patients do not get helped with what we are doing, and then we refer for ART, assisted reproductive technology. Do remember that one third of the patients coming to you with subfertility will have a male factor issue. Others will have female factor, one third, and one third will have both male factor and female factor. So if you've identified your patient and your patient has subfertility, make sure that your patient's spouse shows the relevant specialist or comes to you. Do you learn how to use a few medications? Like if it is an ovulation, you might wish to use letrozole or clomiphene in women. For erectile dysfunction, if the hormonal assays are normal, then we would want to begin with tadalafil 5 or 10 milligram. That is what I use most often. But let's come to our quiz questions for today. So the first question is, which of the following is a potential impact of uncontrolled diabetes on fertility? Does uncontrolled diabetes A. increase fertility, B. reduce fertility, C. have no effect on fertility, or D. does it enhance reproductive health? So, what is the potential impact of uncontrolled diabetes on fertility in both men and women? A. increase in fertility, B. reduction, C. no effect, and D. enhanced reproductive health. Second question, which type of diabetes is associated with higher risk of fertility issues? Where is the risk of infertility the highest? Is it in type 1 diabetes, gestational diabetes in pregnancy, LADA, or type 2 diabetes? So A, type 1, B, GDM, C, LADA, and D, type 2. Which of these is associated with the highest risk of infertility? With this, we come to the end of our. And we take up the questions. I apologize. I think I kicked myself out of it. And good evening, Manu. Thanks for being with us. Good evening, Dr. Ranjit Pratap as well. Dr. Pratap works in Prompet, so it's good to be with you. Uh, Dr. Gauri Shankar, thank you, sir, for your kind words. I feel that we are all together in one big, huge family, and it is very heartening to hear your words, to hear these inspiring words. Dr. Gauri Shankar shares a clinical challenge. 65-year-old gentleman with diabetes. Glucose is not so good, 264, random. Complains of shoulder pain. Okay, not related to range of movement, but pain is there. So let us see how we diagnose. Now, patient has shoulder pain. First of all, it can be referred pain. It might be cardiac. We assume that the tests have been done. Also, it might be from the gallbladder. So no harm in getting an ultrasound gallbladder done. Now, there is no limitation in range of movement, which means that the bones and the joints are okay. The muscle is also okay. Remember something called the Moan syndrome, MOAN, Moan. Moan syndrome is it helps us diagnose the cause of pain. Patient has got pain, patient is moaning. So M can be because of muscle, O because of osteo or bone, A because of arthro or joint. But in all these, the range of movement will be impaired, and whenever the patient moves, patient will have more pain. Whenever patient exercises, there will be more pain. So MOA are out. Now N is neuropathy. Assuming that the ultrasound gallbladder is normal and cardiac is normal, this patient will probably have a neuropathy, and we can fix it easily. Cardiac, we should do proper evaluation. Uh, on history, if the shoulder pain increases on exertion or excitement, exertion physical, excitement psychosocial, then think of heart. Otherwise, think of neuropathy. This neuropathic pain, patient will say, when I am working, I am fine. But the moment I am sitting idle in my office, or I am lying down, or I am resting in the evening, going to bed at night, then my pain comes. And it goes away on its own also after half an hour. But that time I am distressed. So, simplest treatment would be maybe gabapentin or pregabalin. If it is 65-year-old gentleman and non-alcoholic, begin with 50 milligram pregabalin or maybe 100 milligram gabapentin. Wait for 5 or 10 days. Counsel the patient, yes, sir, we can fix you. I am very sure that because your pain is not increasing on exertion or excitement, it is not cardiac. Don't worry. You got your ultrasound done, there's no stone also, so don't worry. And see, your MOA, muscle, ortho, and arthro are normal, so I will not get any test done. Let me save you the money that you would otherwise have spent on getting x rays and MRIs. Now, for neuropathy, one is you give uh, the nerve stabilizer, which is pregabalin gabapentin. If that doesn't work, you can add a second drug, duloxetine, if your patient has got depressive symptoms, depressive overlay, and amitriptyline, if your patient says that pregabalin is not working at all. But in 65-year-old gentlemen, risk of amitriptyline is that it might cause urinary retention and it might cause orthostatic hypotension, dizziness. So when patient wakes up at night, he might feel dizzy to go to bathroom. If at all you have to start, you start 10 milligram. So the combinations will be pregabalin 50 plus nortriptyline 10 milligram or pregabalin 50 plus duloxetine 20 milligram. This will be second line. Apart from that, you have to give a what we call nutritional optimization. So nutritional optimization means uh, first of all, ensure that the hydration is good. Drink water. Ensure uh, electrolyte balance. Maybe patient has got heat exhaustion. Maybe patient has got hyponatremia. So give the appropriate electrolyte drinks. Also vitamins, vitamin B and vitamin D. These are the ones we have to focus on. So ensure nutritional optimization and also give a nerve stabilizer. We welcome Dr. Anshul Singhai and Dr. Vinayak Sharma. Thanks for being with us. Now, Dr. Gauri Shankar sir shares a separate clinical case. 55-year-old lady with the continuous knee pain and painkiller no response. This is quite common. So some of the things we can do are you can tell your patient, please get an MRI done. X-ray will show you only bone disease. But supposing the ligament is torn or the meniscus is torn, that we will get to know only from the MRI. While you are waiting for the MRI, everybody cannot afford in one day. You can and do any of the following. You can use a centrally acting painkiller like tramadol, tapentadol, nefopam, Nefopam, or flupirtine, Flupirtine. You add these, any one of these, for short period of time, for few weeks to whatever NSAID you are giving. At the same time, because the pain is continuous, we give the same nerve stabilizers. So pregabalin or gabapentin plus duloxetine or amitriptyline. Start with that. Third thing, other intervention, we can send patient to physiotherapist, and the physiotherapy will do what is called TENS, TENS, transcutaneous electric nerve stimulation. This may help the patient. If your physiotherapist says that she is not experienced in TENS, she can give IFT, interferential therapy. This will also help. Muscular pain, first of all, give rest to the muscle. That is how to handle muscular pain in diabetes. Also, see if your patient is on high dose of statin. If you are worried about statin induced myalgia, statin induced myositis, get a CPK done. If CPK is high, that is myositis. If there is myositis, then we have to do urine heme, HEME, urine heme test that will tell us if patient has got rhabdomyolysis or not. Stop statins, support the patient with uh, diet, hydration, electrolytes, and rest, and give painkiller for short period of time. Supposing patient has only myalgia, that is pain, but CPK is normal. then you may wish to stop statin for short period of time. Give good quality hydration, electrolytes, vitamin D, and sometimes empirically I use vitamin E and levocarnitine, and that helps the patient. Always good idea to talk about diet, about folk therapy, folk medicine. So in winter here we talk about turmeric. So in Haryana we will say आप हल्दी वाला दूध पिएं to reduce the inflammation in the muscle, and it actually helps. We specify also tazi haldi, that is a fresh haldi, fresh turmeric. You get it from the farm, grate it, and use that in your milk. Neck and shoulder pain is usually muscular, that is right, and after that it will be bone related. So get an X-ray cervical spine. If there is cervical spondylitis, then again the management will be same that we had mentioned earlier. Dr. Anshul Singh points out, and rightfully so, that duloxetine 20 can be a choice for neuropathic pain. So if the patient has got depressive symptoms, apart from pregabalin, you can also use duloxetine as first line. Only message I would like to convey is that when you start a drug, start low, go slow, start with only monotherapy, at least for a week or 10 days, then you can go up to dual therapy. However, if patient has already been taking monotherapy from an earlier doctor, or patient comes and says, "Sir, I'm in so much pain, I'm thinking of leaving this world," then don't wait. Please start dual therapy together. Just call the patient back for regular follow-up. If it is very elderly patient, avoid giving amitriptyline at first line as first line. Just make sure that your patient does not have autonomic neuropathy, does not have prostate. Thank you, Dr. Ranjit, for answering the questions, and thanks, Anshul, for being with us. One question from Dr. Shashi Khare. Uh, so, just on a personal note, Dr. Jaideep Khare is a very close friend from Bhopal, and recently he has become professor of endocrinology at the prestigious People's Medical College in Bhopal. So, Dr. Shashi, please join us in congratulating Dr. Jaideep, Professor Jaideep Khare at all. So, I don't think he'll be listening to us today, but he has become a professor, and I'm very happy. So Dr. Shashi shares the case of a 60-year-old lady on oral antidiabetic. Okay, having this is very common, Dr. Khare, having aches and pains in lower limbs with HbA1c7. So what are the probable causes? Let us go stepwise how I do. Lemon approach, LEMON. L for lifestyle. Does the patient exercise? If she is not exercising at all, that means she is not fit. So we make her exercise. Is she exercising too much? Maybe she is a housewife, she is on her feet 12 hours a day. So then you tell her, madam, you have to work, you remain standing, but every 20 minutes, try to sit down for 20 seconds, please. 20 by 20 rule. Every 20 minutes, sit down. Another way is if you are standing like this, like I am standing right now, that is actually quite painful. But I keep on moving my ankles. So, two exercises for this lady. We are at lemon right now. Lemon lifestyle. So, one is toe touch. Put your toes on the feet. I'm doing that right now. And try to hyper extend your foot. Take your foot as upwards as possible, keeping your toes on the ground. You can do that while sitting. And what you will see is there'll be a stretch on the calf muscles. So do for 10 seconds, then go back. Now my entire foot is on the ground. Now again, toe touch. Toe on the ground, heels as up as possible. Again, there is stretch on the calf muscles. So keep on doing this every now and then. The circulation will start in the calf muscles, that aching pain will go away. Opposite exercise, heel touch. Keep your feet on the ground, extend your toes as upwards as possible. Again, there is a stretch on the calf muscles. Hold for 10 seconds and go back. So we are answering Dr. Khare's question, how to handle aching pain in lower limb. L for lifestyle. Don't stand too much. Don't stand too little. Take breaks in between. Keep on exercising your calf muscles. E is for endocrine. So first of all, of course, glycemic control is there that we have managed. But within glycemic control, suppose we are giving pioglitazone. That can cause slight edema, and that can cause slight aching pain. So if there is pioglitazone, try to stop in this lady. As it is, pioglitazone will be associated with greater risk of fracture, and this is postmenopausal woman. So I think we should stop. Uh, Other endocrine, I think TSH, calcium alkaline phosphatase. TSH, calcium alkaline phosphatase. These tests should be done. M is for medical and metabolic. So here, in a lady, chances are less, but take a history of smoking. If there is a history of smoking, or there is a history of pain that increases on exercise, claudication pain, then maybe we should get a lipid profile, and maybe we should get a Doppler, an arterial Doppler of the legs. Metabolic would also be for renal, hepatic, heart failure. So do all the routine tests. Maybe there is some systemic disease, uh, kidney disease, heart disease, lung disease, liver disease. So these are things to look at. L was for lifestyle and exercise, E was for endocrine, M was for medical metabolic, O is for orthotic. Orthotic means the feet, the footwear. What kind of footwear is she wearing? So, madam, why don't you check? Do you have more pain when you wear heels or more pain when you wear flat slippers? Uh, Try to change your shoes, try to change your footwear every 2 to 3 hours, because in every footwear the pressure points are different. So just change and see what happens. You're at home or you're at work, you wear different slippers, different shoes for every few hours. And the last is nutritional, which is very important. So this ache and pain can be because of dyselectrolytemia. So make sure that potassium is okay, make sure that hydration is okay. It can also be because of micronutrient deficiency. So anemia would be a big cause. And try to use good quality hematinics. Earlier, the hematinics that we had, they were associated with a lot of GI disturbance. But now we have nanotechnology iron, and I think Mr. Basu is the expert on that. He will add more to our information. How has nanotechnology iron changed changed the way in which our patients accept insulin, accept iron, and adhere to iron? In macronutrients, we have protein. So, protein deficiency is very common in India, especially in 60-year-old ladies. So, try to increase protein content. Just tell the lady, madam, no need to buy expensive products, but if you are eating egg, every time you have egg, you eat double, just eat one extra. Every time you are taking fish or chicken, eat one extra. You are not non-vegetarian, doesn't matter at all. Whenever there is milk or cheese on the table, take two helpings. Whenever there is dal or rajma or chana on the table, take two helpings. So this is Dr. Shashi. Thank you for raising this, and I would also like to thank Dr. Gauri Shankar for raising these questions, because these actually help improve the quality of our diabetes essentials. Uh, Mr. Basu shares the case of a gentleman who was asked to do an atherectomy, angiogram, and then atherectomy. And while he was undergoing that, his shoulder pain got relieved. So actually, it was a cardiac cause. Dr. Gauri Shankar says if hydrocortisone can be given for pain, yes, it can. Orthopedic surgeons, rheumatologists, they use it, and it is safe to use. Just keep the glucose control normal. One last case that okay, now this answer I am not very confident, Dr. Gaurashankar, but 37-year-old gentleman, so we have to be aggressive because he is only 37 years young. He has claudication pain. There will be a vascular component and a metabolic component. So metabolic we will correct. Doppler shows 80% block before popliteal artery. So this is limb threatening, and patient should be referred. We should not keep in GP small clinic, because if you give heparin, first of all, bleeding tendency will be more. Secondly, we will not be able to fix the 80% block. It will be temporary relief. This patient will have to go to cardiovascular surgeon or cardiologist, and just like they do angioplasty for the heart, they will do a peripheral angioplasty for this patient, and they will put a stent in the artery. So this patient should not be kept in our clinic. They should be referred to a CTVS specialist, that is surgeon, or a cardiologist, whoever is willing to do the angioplasty. Possible Possibility is there that cardiologist may say no, this patient is not fit for angioplasty because the blockage is very long. Then in such patients we have to give send for surgery. They will do a bypass. One more question from Dr. Singhai. Musculoskeletal pain is common in people with type 2 diabetes. With SGLT2 inhibitor, what happens is generalized weakness sometimes. So, two options. If you wish to give the SGLT2 inhibitor, you add something like an Erzal 0 and help the patient maintain hydration and electrolyte balance. Second is just stop for a few days and then see what happens. So, both ways are equally okay. So, with this, I'd like to thank you all for being with us this Sunday evening. Thank you, Mr. Basu, for continuing to be with us. Your comments on what we have discussed today.
Sir, I think the range of questions which we received is once again proving that you have been reached to almost on a live basis. At least 600 to 700 doctors are listening to you. At the same time, on a week basis, I see there is around 1500 to 2000 doctors are watching. Once again, back that talks about the popularity of our diabetes essential. Although we are running on for the third year, and it all the credit and the everything goes to you because of the design aspect of the content is so well that today topic, and when I was listening, and after that one of the follow-up questions we are having, I'm sure there are more follow-up questions we will be having from day-to-day practice which our listeners are watching and they're putting across to you. But coming back to the today's topic, I think that the today's topic was very, very I would say apt as well as very common and nowadays where there are delayed marriages and both husband and wife want to conceive as early as possible, but at the same time probably most of them are pre-diabetic and they come up with so many problems to conceive. So that talks about the today's topic, and sincerely thanking Dr. Sanjay Kalra for taking the topic and answering all the questions very tolerantly and very patiently. With this, I sincerely thank Sanjay sir for being with us. Yeah, I also get that comment from Dr. Gauri Sankar that it's a brilliant session. And take care, sir. Good day and good night and Jai Hind, sir.
Jai Hind.